questions, you can definitely type it into the chat box, and we will make sure that we answer your questions. And also to those in the room, we're pretty mic'd up and we're recording, so just an FYI that it can pick up all sorts of sounds. Oh, really? That's your opening your back. Okay, so before we start off, I wanted to first of all acknowledge where we are here today at the University of Manitoba, the Georgian Fahey Center for Healthcare Innovation. We want to acknowledge that we're gathered today on Treaty 1 land, home of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and homeland of the Métis Nation. And when we come here together today, we respect the treaties that were made on these territories, we acknowledge the harms and mistakes of the past, and we recognize the ongoing present-day colonial violence that is faced by Indigenous peoples in the healthcare system, the justice system, and the academic system, and we dedicate ourselves to moving forward in partnership in a spirit of reconciliation and collaboration. So today we're here gathered to talk a little bit about budgeting for patient and public engagement, which is a hot topic. It's something that I get asked a lot about by health researchers. And it's really important to make sure that you make a really appropriate and comprehensive budget when you are thinking of engaging people with lived experience, caregivers, families, communities. So today we're just going to do a brief overview just to make sure we're all on the same page. What is patient and public engagement in health research? Then we're going to talk a little bit about barriers to patient and public engagement in health research, because this is going to be helpful to you for when you start building your budget, because you want to build a budget that facilitates engagement and looks at and addresses some of the barriers that might be faced when you go to engage. So first of all, the Georgian Fahey Center for Healthcare Innovation is part of a national strategy called the Strategy for Patient-Oriented Research. And people often say, well, what is patient-oriented research? Well, it's a continuum of research that does 5 things. Engages patients as partners, focuses on patient-identified priorities, improves patient outcomes, is conducted by a multidisciplinary team in partnership with relevant stakeholders, and aims to apply the knowledge generated to improve healthcare systems and practices. Notice that I capitalize and underline the "and" because a lot of times I have health researchers tell me, I'm doing patient-oriented research, I'm doing research that helps improve patient outcomes. But when we talk about patient-oriented research, we want to look at all 5 of these components as a continuum of research. So it has to engage people with lived experience and focus on patient-identified priorities. And the Canadian Institutes of Health Research, the Strategy for Patient-Oriented Research, defined patient and public engagement as the meaningful and active involvement of patients in the governance of research. So when you think about steering committees, research teams, people are co-researchers, people are on your team, the priority setting of research, the conducting of research, and the knowledge translation of research. But I really like some other definitions that are put out there. So involve, which is from the UK, they define it as public involvement. And it's seen as involvement in research, so research that's carried out with or by members of the public rather than to, about, or for them. And for me, when I'm talking to health researchers, one of the most important things I usually say is it's all about people, informal caregivers, communities with lived experience of a health issue having a say in decision-making about the research process. So this means it's a co-production of knowledge. You're working together collaboratively and making decisions together. So this means people with lived experience, communities, caregivers having a say, so identifying research priorities that actually matter to them most. We've had times where health researchers are looking at rheumatoid arthritis, and they think the most important thing for patient partners is pain management, when really they gather people together and the feedback was it's actually fatigue. getting out of bed, taking the kids to school, going to work. These are the things that I struggle with the most. This is the priority that really means something to me. Helping to shape and clarify research questions. So we've had research where people with lived experience of mental health um, reshape or redefine the research question to a more strengths-based versus a deficit-based. So let's talk about moving towards recovery and take a recovery lens versus looking at challenges and barriers instead. So just rejigging it and in doing so, that actually attracted more people to the research study because they felt that it spoke to them more. Helping to ensure that methods or the designs that are being proposed in your research study are actually appropriate and acceptable and sensitive. So we've had ones where people with lived experience of chronic pain, the research design was this really long survey that they had to fill out. And so they engaged people with lived experience on the research team, and they redesigned the whole thing so that it was a shorter, self-paced questionnaire that was actually done over the phone instead of having to fill it out. Making sure that research outcomes that are actually have meaning to people with lived experience. We've had times where outcome measures that researchers hadn't even thought about before engaging people with lived experience were identified. So there was one around hospital care, and patient partners actually identified, well, I'm more concerned about the days that I can get away from the hospital and how many days am I at home versus how many days I'm in there. And so rejigging some of the outcome measures. Helping ensure that the language and the content of the research study itself is accessible to potential participants, right? If you're going to recruit participants, you want to make sure that the language is accessible and that it really talks to people. Helping to increase participation, so different knowledge networks, people with lived experience can help increase that way. Identifying new areas, that's one of the ones that we see a lot when we engage. People with lived experience identify completely new areas of research that should be looked at. Interpreting research findings, we have people with lived experience that help interpret data, theme data, methods of dissemination, knowledge translation, as we say. This is another area where people can be actively involved in helping with some of the methods. And then ensuring overall that the research actually reflects priorities and needs of community. Now, before we start getting into the budgeting aspect, we really want to talk about what are some of the barriers for people when they come to engage. And so what people are actually being engaged about. So if it's an abstract healthcare issue about, say, perchance planning two overarching healthcare strategies, as opposed to direct service, it might not be relevant to people. People might not connect with it because they don't know. If they have to be actively trained in order to engage, that time commitment to do the training may be a barrier as well to engagement. It may take low priority to certain people who are dealing with chronic health conditions and other barriers to actually engage. So people oftentimes, some of the literature shows that people will oftentimes spend more time when they connect personally with the topic. So it's important really to engage people from the very beginning in the priority setting phase and the research design and question phase. So then it's actually research that's relevant to people. Learning about the opportunity. We wouldn't think about this, but sometimes people can engage because they have no idea that there is an opportunity to engage on a health research question. Oftentimes, people are recruited by, say, health service providers from whom they receive care. They'll find out about an opportunity. But many of the groups that aren't traditionally engaged in the first place in health research, including people, say, living with substance use issues, mental health issues, trauma, poverty, may not even be accessing the healthcare service that where you are recruiting. So they may not even learn about the engagement. So this means that you have to think creatively about how you're going to even get people involved in engagement in the first place. Language barriers is a big one too. So people may have language barriers which prevent them from understanding when you do put out a recruitment or a solicitation, it's only in English. If you're relying on English-speaking health service providers to talk to people or health researchers, they may only seek input from people who speak primarily in English. So how are you going to recruit people who speak different languages? This is a barrier. Healthcare service professionals and health researchers oftentimes don't seek the input of people who they think are living with a lower cognitive function, which is also a barrier because people can be engaged in many different ways, and it's all about finding ways to creatively engage people. Time and energy commitment. By choosing to become involved in health research, people are deciding that they're willing to commit their time, their energy, because they believe there's something of value in the involvement. The amount of time and energy that they place in it will vary depending on the engagement method that you use. So if it's a one-time event, literature reviews have shown there's more engagement ongoing. There's going to have to be a stronger motivation to engage and make sure that you're hitting all those and make sure that you're addressing any potential barriers. Sometimes people don't engage because they don't feel that they have the capacity or the skills to actually participate in health research. Certain groups, such as women, so if you take a sex and gender-based analysis, women may be less likely to see themselves as having something to contribute, especially around health policy issues, because of past experiences with institutional discrimination or internalized stereotypes about political abilities. And across literature and interviews, a lot of women who had a history of trauma or substance use, who had negative experiences with healthcare providers, healthcare institutions, where they felt that providers were stigmatizing them, didn't feel comfortable in actually then participating or engaging in health research. So you need to be cognizant of what the history is, the different communities and different people around engagement. Again, trauma and mistrust. So if you've had trauma in the healthcare system, there might be a mistrust of certain types of institutions. And also, so that may deter people who have concerns about engaging with an unfamiliar institution around health research. So understanding those barriers. And then the biggest thing, and then one of the other areas is actually just getting there and getting involved. So even when people do have an opportunity to engage and they want to become involved, there's other factors that can prevent them from actually attending. So childcare responsibilities is a big one. Care responsibilities for another adult. We live in a generation where someone may be looking after their child, but also an elderly parent. Understanding that as a barrier. Flexible employment schedules. This happens a lot. Some people have jobs which they can't change around their schedules, and it can be a barrier. Household responsibilities, access to transportation, unstable housing. So if you don't have stable housing, you may be couch surfing or so on. You may not be able to dedicate time continuously, figure out ways to meet people where they're at instead. Unpredictable schedules, people who are temporary or precarious jobs, it's difficult to schedule yourself. Things like food insecurity and basic survival stuff may be a higher priority to people than engagement, and understanding that people may be facing some of these barriers when you ask them to engage. And different people experience barriers in different ways, right? So women, again, the sex and gender-based analysis, women are likely to experience a lot of those barriers, such as that are around gender prescribed roles. So the caregiving, providing care to family, children, aging parent, inability to leave dependents at home or afford alternative caregiving, all these people. And then everything's compounded by low socioeconomic status. This was, in all of the literature, this was one of the biggest barriers to engagement overall, was low socioeconomic status. It creates a barrier in itself in order to, and it has to be something that's addressed in engagement activities to meet people where they're at. The setting of the event is a huge one and an important consideration where you put your event, where your event occurs. Some people may be physically incapable of attending and may be housebound. So how are you going to engage those voices? The location of power. We talk about this one a lot. And then in one of our last ones, we talked about understanding our own social location. So as health researchers, as people with lived experience, when we all come together, we need to understand where the power dynamics at play, and we need to be able to have discussions on this. And there's a variety of mechanisms power dynamics come into play, and that shapes how people will engage, how they want to be engaged, and how they'll come together. So we have to really address those pieces as well. Other areas before not feeling safe is also when it's scheduled. Remember, when you schedule an event, if you're scheduling an event during a work week, during a work day, people may not be able to attend because they're working during the daytime. So those ones are important. And we talked about where it's held. One of the biggest things, if people have experienced any type of trauma around the healthcare system, they may not want to come to a hospital and engage. People have had bad experiences within academic institutions. They may want to go to a community space as well. Rural and remote, if you have it in the city, you've got to understand what kind of barriers occur in there as well. And how how the engagement is actually done as well. You can do an online survey. People don't have internet access, doesn't really work. If you do a workshop where it's all about scientific literature, that doesn't, and people don't feel like they have the capacity to do this, it also doesn't work. So it's really important to address things like safety, make sure people feel safe when they're going, and also who facilitates. Who facilitates your event can be a barrier as well. If it's a healthcare provider or health researcher and people feel like if they say something, it may harm their care, that's really important to address and understand. These are all bits of things that are important. So your facilitator is a huge question. Other patient-public partners, there are certain things when we share our health experiences, they can be really sensitive. And so it's important to understand that some people may feel that their experience is not the same as everyone else's and may feel afraid to share, but to address those differences at the very beginning and make sure everyone feels that we're talking in a non-judgmental way and that we're able to open safe spaces is really important. And a lot of the feedback from interviews actually had people were worried to offend the health researcher by criticizing them. So there's a lot of times people are just concerned about these types of things as well. The style of engagement. So people engage differently and the way we express ourselves is different. And so we may differ as far as the way we deliberate as well. And there's been things around gender differences. Some people use more narrative and emotionally ways of expressing themselves. And sometimes the way, the participatory approach that we choose to engage people ends up being a barrier because it favors or prioritizes people who speak in a very deliberative, articulate way versus an emotional way. So we have to really understand, even the participatory approach that we use needs to consider the different ways in which people communicate as well. And then the types of evidence. So there's been criticism sometimes of different approaches like citizen panels, where experts present the evidence and then citizens make a decision. While you're controlling the evidence, you're predetermining which evidence you're going to present to citizens, and it doesn't allow for enough space for experiential knowledge to come in. So there's a lot of different ways in which there could be barriers to engagement. So how do we start addressing that when we're building our budget for engagement? First of all, my biggest thing is compensation for time, energy, and expertise. This is something that gets debated a lot. But for me, it's about the co-production of knowledge, that we're coming together. Health researchers are getting a benefit from doing this research, whether it's tenure status, whether it's moving up in pay. There is a benefit that they are getting from doing this research. So people that bring their time and their energy and their expertise are also great value, and so they should be accordingly compensated. And this can include a number of ways, because we've had conversations about this before. So it can be a fixed service income, either hourly or daily. We've had patient partners who are research assistants on our team and are paid as a research assistant. We have had co-researchers on our team, patient partners, who have also done this as well. So these are ways. It's important to always pay people living wage as well, make sure that we are compensating fairly. It could be an honorarium for attending a workshop or are spending on an advisory board that doesn't meet very often. It can be in-kind compensation or a gift. So sometimes people don't want to be paid in a monetary way because it may impact other things like disability pay, may impact unemployment insurance, all of those things. So we want to make sure that we have those conversations out front, which is the best way to compensate you for your time. And so we've seen at times we can compensate people with lived experience by providing something that can help them on their journey to recovery. So yoga classes, tuition for a course, upgraded Word for their computer, right? A program for their day. There's many, many ways people can be compensated, and it's just all about having honest conversations up front with people about it. And then there are some people who very much just want to volunteer their time and want the money to be donated to a charity of their choice, and that's happened before where the money has been donated to charity of their choice. The biggest thing is just have the conversation out front. Have the conversation one-on-one, not as a group, because that can be, if you ask the whole entire group, people may not feel comfortable expressing the way they want to be compensated. So talk to people one-on-one at the very beginning. Education, training, mentorship, and practical research experience. We don't always budget this in our patient engagement budgets, but it's really important. It's a two-way sharing of knowledge, but it's also a two-way sharing of financial resources to support opportunities, right? For further education, if our patient partners want to attend a course, if they want to take some training, if they want to enroll in a mentorship program, if they just want to be engaged in practical research experience. All of these things need to be considered when you are engaging full with lived experience and in your budget. So that can mean even presenting the work at a conference. This happens a lot. We engage people and we don't put in at the end for accommodation, registration, and flight for our patient partner to come and present with us, or our community partner. Budget this in, make sure that you put this in your budget ahead of time, so then people aren't missing out on possible opportunities that they should be offered. Oh, we talked about getting the word out. Make sure if you want to use different methods to get the word out about engagement, that you include that in your budget as well. So does that mean putting posters up in community organizations? Does that mean working with different knowledge networks and knowledge brokers in communities to get the word out? Make sure that you budget that in as well. Interpreters and translation services. This is a really important one, and we don't always see it in budgets for patient and public engagement. This is a huge barrier for engagement. It needs to be considered. So both translation, so your materials when you are doing your engagement activity are in different languages, but also interpreters as well who may be present. So it's important to consider and have conversations around how people feel most comfortable in communicating, and so that's not a barrier to being able to participate. Assistive technologies. This is an important one as well. We don't always think about for individuals who are living with disabilities. There are many different ways we can learn a lot from universal design in classrooms. So thinking about interactive whiteboards, thinking about things like text-to-speech software, speech-to-text software, text enlargement screens, classroom amplification systems, thinking about the having iPads. Sometimes we use iPads or different mobile technologies so that people can participate in ways that they feel most comfortable and that we're not in any way creating a barrier. We also want to think about care attendants and caregivers. So some people with lived experience of health issues may require a care attendant to attend with them. So that means factoring in compensation, food, accommodation, travel, all of these things as well for the care attendant or the person coming. And this is often overlooked as well in some of the budgets. Transportation. So in addition to local transportation, a lot of times we think about buses, taxis, car mileage. We also have to think about transportation from remote and rural, so thinking about, or distant areas, thinking about flights, trains, ferries, and always, this is the number, this is a big one now, luggage fees, right? Because we can pay for the flight, but then that darn $28 luggage fee comes. So make sure you factor in all of these things so there is no out-of-pocket expense for people with lived experience when they're traveling. Parking, the age-old dilemma of parking. I know with us, we try to actually do engagement activities where there's free parking. So we go out in the community, we find places where there's no expense. But if you are engaging at a place that has parking fees, it's really good to have parking passes on hand ahead of time so that there's no out-of-pocket expenses, if that's possible. So nobody ever incurs any type of out-of-pocket expense. Caregiving. So this means both for children, but also for other adults who may be looked after as well. So caregiving for respite, for childcare, or for daycare. Understanding that this can be a barrier to people's engagement and factoring that in as a possibility in your budget to make sure that people don't face that barrier when they want to go. Accommodations is another important thing. So thinking about a lot of times people with lived experience of chronic health conditions, asking them to travel, even, 2 hours one way, 2 hours back, that's a lot to ask in one day. It's exhausting. Make sure you have a conversation and, get accommodations for them so they can take a break in between. When you're looking at accommodations, make sure if they say that they have accommodations for people living with physical disabilities, that's actually true. Take a look at the rooms. Sometimes we've had experiences where hotels have accommodations for people living with disabilities who use wheelchairs, but scooters, there's not, the room doesn't work. So understanding that ahead of time when you're booking rooms for people is really important. And going and seeing yourself visually that is a room that's actually fully accessible to people. So accessible spaces is really important, and understanding that people are differently abled. And even so, when you do workshops and meetings, going around the room and understanding how people can navigate the room, where there's times where there might be breaks, bumps, things like that, that may cause a barrier to people engaging. And also, I remember a patient public advisor once told us, make sure to, if certain people have hearing impairment or are visual, that they get to come early. Well, anybody who may be living with a disability, they can come early and pick a spot that they feel is the best for them in a room before everyone else arrives. So they can participate. And also, again, the safe spaces, make sure you think about where you're locating your space as well. But this is something you have to budget into put into your budget sometimes, because the space may cost money to book, to rent, the AV system, all of those things. Healthy snacks and meals. How many of you have been at meetings where there's no food or beverages? You get very hangry. These are important things. Engagement is about relationship building. It should have some food in there too, right? What better way to have conversations than have good food and nutritious food too, not just muffins and like sugary stuff, but good food, fruits, vegetables, those types of things. And snacks. There's been times where I've been at things that only just have meals but no snacks. Come on, give us something a little bit better. Even one-off meetings that you expect people to come right after work should have some food there, right? It's meal time, and then you're asking them to come and engage. Probably provide a little something to munch on. Printing materials. So people with lived experience should never have to print out materials on their own home stuff or any of that, right? There should never, human resources, financial resources should be completely looked after, so that nobody's out of pocket or burning through their ink at home. So make sure you do all of this ahead of time, and you budget for it, right? If you require that. Elders, counselors, and supports. So making sure that payment for elders, counselors, and supports, that who you want to invite to attend, thinking about gifts such as tobacco, and compensation for people's time for coming and their contribution to the meeting is really important. Remember that's important for people with lived experience to have supports at events too, recognizing that sometimes what we're talking about, the experiential knowledge that we're asking people to share, can also be intertwined with experiences of trauma. So making sure you account for that and you appropriately compensate people for their time when they do come. Gifts for speakers. We've had times where we've had events where patient partners, people with lived experience, have told their stories and have presented and gone out of their way. They put, PowerPoints, all these types of things. Make sure you have a gift on top of compensation and all those other things. But think about, something that they might take away with them. And coffee mugs, small works of art, those types of gift cards, those types of things as well. Yes. Now, professional facilitators, this is a question a lot of people have. Sometimes people prefer to have a professional facilitator help everyone navigate through a conversation, especially if it's a difficult subject matter. Again, when you're building your budget, think about this. And by a professional facilitator, it can be somebody from the community, somebody somebody who has connection. You should still pay them for facilitating and help guiding a conversation, right? So make sure you factor that in. Now, are there anything that anyone can think of that I might be missing from here? Also, webinar people. Yes.
Just had an experience once when, like I love that you say no out-of-pocket expense. Yeah, sometimes we have the greatest intentions, but there's people from a rural community come in and they need to have had a credit card to have incidentals on their card at the hotel, and they don't have a credit card.
Yes.
Also expenses along the road before you even have contact with them, like getting them cash in hand. And for a university-based program, often we have per diems that are so grossly unrealistic for ourselves, and we're able to top up that with our own money. But perhaps the community member has not been able to do so and has a sense of pride that they don't want to share that. But an intermediary, not yourselves even, like I appreciate, you said, have a direct conversation with them. Sometimes there's even that level of discomfort that you need that intermediary from the community, someone trusted to have that conversation with them, because we didn't know that they didn't have enough cash, and also allowing enough time for the university to get cash in hand. Like our processes are so bureaucratic that it takes time to get cash.
Yeah.
So that's a couple of things that I just had in my list.
Absolutely, absolutely. Those are all things we've encountered as well. The credit card issue for the accommodations we've had. I think at one point in time we had to phone, like on a weekend, we had to phone with the credit card because our partner had arrived and they were asking for this information. So making sure that they have that information ahead of time when they come. Same with the yes, the per diems is a huge issue as well, because people may want water or nuts, or when they're traveling on a plane, right? Small amounts of things. So getting cash early can sometimes help. If you can, a lot of times it's playing a little bit around the system to make sure that people do get a little cash on hand and maybe claim it right, those types of pieces. Absolutely, those are definitely some big ones. The expense as well. So we've been trying to use that one as far as the university setting. It's tough sometimes because universities take forever to pay back the amount. So making sure that we pay ahead of time with our credit card, those types of things. And we're still navigating, and I think there's still ongoing conversations. Even we found around salary and employment that a patient partner is a research assistant, and making sure they get paid in a certain way, in a certain manner. All of those things have definitely, and I think it's going to be an ongoing conversation. I think a lot of people over the years doing community participatory research action have started finding ways to navigate, and we just have to share a little bit more about the different ways in which we've been able to find a way to make sure that nobody goes out of pocket. Yes, we have a question from the webinar.
Yeah, we have a comment from the chat. Another thing to consider when budgeting, pay cash fund, things like reimbursing parking costs on the spot, like merge.
Oh, great.
As well as free.
Yes. So petty cash. If people didn't hear that one, that's a good one too. Making sure that you have petty cash on hand to give people for parking. If you can't provide the parking pass right away, those things are just anything, snacks, water, like things while they're traveling as well. Any other ones that people can think of?
I like the asking them how to be compensated. We did that. Everybody wants cash. Good.
Yeah.
The university was offering or pushing people to get gift cards for first. Nobody wants gift cards.
Nobody wants gift cards. Yeah. So asking, or as we were suggesting too, having a knowledge broker who may be able to bring forward if there is an issue with payment, and feels comfortable enough with the team to kind of bring that up.
Well, we have another comment from the chat.
Yes.
Researchers should go to the community instead of having community patients who to academic space that can be intimidating.
Absolutely. That's a great one. So if you didn't hear that, that's researchers should come to the community versus vice versa. So that means in your budget, making sure that you have travel to get to a community, that's factored in as well. That's a very important. I think it's one of the things that we keep really talking about here is that meeting people where they're at versus trying to bring everyone into a research thing.
That means renting community spaces.
Yes, renting community, locally owned community spaces. One of our big things when we do engagement is also getting food from locally owned businesses. So supporting businesses that, they're locally owned food. Even community members as facilitators, making sure that support community.
I just have a question.
Yes.
So kind of along the lines of what you're saying back there about the per diems, and I know the university per diems are like super low. But when you do have a patient or a partner coming to an event, obviously you have to have a conversation at some point about per diems in order to make your budget, right? So if they are to come to an event, say you're a conference for a weekend and you have no idea what they're going to spend. You don't know where they're going to eat. You don't know if they're going to buy a bunch of snacks in the plane and then at the airport. So how do you navigate those types of decisions? Like, do you come up with a number ahead of time for them?
Wouldn't they use university money?
Well, it's so low. I mean, people can't. It's like it's a 50, I think.
Well, it's $15 a day for example. All the snacks, etc. And there's 20. Might have gone up.
Maybe it went up because I thought it was
And
lower
it
than
differs
that.
if it's in Canada versus international.
Yeah, it always is different, but I remember it being lower. So maybe they've improved it.
So some of the per diems, so having those conversations ahead of time. A lot of times I make sure if I'm going to the same conference as a person with lived experience that I am there to pay for their meals.
Right.
And so there's no having to expense anything. So I'm sure, and if snacks or whatever comes out, I can make sure that I'm paying for it and they're not having to pay out of pocket. But yes, if they're traveling on their own, if they're again, I think the petty cash are finding ways to get around that by giving actual cash on hand can work, and perhaps just budgeting in a little bit more.
Yeah, I guess the cash of giving cash ahead, and you wouldn't have a problem
Yes.
of incurring expenses that you weren't expecting, I guess.
Because taxis too can be
Yes.
super expensive. I know we've gone to events in Ottawa and the airport is very far away
Yeah.
from the downtown, so it's like a $45. So having that money on hand, or when I'm with someone, I make sure
Take
that I pay the taxi ride as well. That we're staying at the same place, and that I can make sure that it is being covered and so on.
Excellent. Is there,
Yes.
I have a question. Do you have any specific experience working with people you're engaging that are dealing with just navigating basic survival?
So people who are, so say people living in homelessness and those types of pieces as well. So a lot of times in those instances, it's about engaging people where they're at and in ways. I know Sunshine House has an amazing program called Dinner and Sign, where they have a big meal at the house for people who are living in homelessness or living with substance use. And it's a way to bring everyone together, a one-time kind of thing, and have conversations around things that are important to the community, but also providing food, providing care, perhaps having people available to connect with while you're all together as far as healthcare or those. So finding different ways to engage communities and
I think the question implies a good lesson that finding the partner who has done that research, because as researchers, we we come with expectations and certain norms, and it can be very valuable to exchange with another researcher their experience with that population, because I think it's distinctly important to engage with the researcher as well as certainly those agencies and individuals who know about homelessness. But that kind of lens from our normal and what our expectations are, and to speak to the researchers who come at it from their end so that we don't follow the same pitfalls that they have is really great. So if your question was like, have you had the experience of doing that, finding that partner and talking to them beforehand? That would really, really save you a lot.
Yeah, so connecting with other researchers who have engaged different groups and different people ahead of time, and then also community organizations that work with people on an everyday basis and kind of understand ways in which to support and help and make sure that's a two-way kind of beneficial. Is there any more questions? Any more questions online? So our next lunchtime learning is not taking place on the typical day because we have a grand round children on April. So it's going to actually take place on April 4th. So stay tuned. We'll make sure to let everyone know. If anyone has any questions, they can always shoot me an email, meet me. For some reason I don't have my phone number, but I will. You can always send me a line, and I'll be sure to get back. So thanks so much, everyone, for joining us today.